Okay, so our next panel is going to address health insurance and access to addiction services. And our moderator is Lisa Dodson, the Dean of Medical College of Wisconsin, Central Wisconsin, and she will introduce her panelists.
Good morning. I'm Lisa Dodson. I'm the Dean of the Medical College of Wisconsin, Central Wisconsin campus, which is a new medical school campus here in the Wausau area. We were started as a branch or a regional campus of the medical college in recognition of the shortage and maldistribution of primary care physicians and particularly of psychiatrists. So those are the two areas that we're trying to address most with our campus. I would like to say that we're making progress. We're just getting started, but we're going to talk today a little bit about some of those access issues. I'd first like to introduce Brett Davis, who is currently the president and CEO of Aspirus Arise, which he began as his position in 2015. Brett.
Thank you very much.
Thank you.
Can everybody hear me okay? Just learned how to use the microphone in the back, so just wanted to make sure. How's everybody doing? Doing all right? I want to make sure we're livening up the crowd a little bit here. So how many of you are bicyclists and really enjoy bicycling? Beautiful weather over the weekend. Did anybody get out? A few of you? How many of you own a bicycle? Everybody own a bicycle? Well, I was inspired over the weekend. Of course, over the winter, I didn't do a whole lot like I should have. But I was inspired over the weekend of the beautiful weather on Sunday, and I took advantage of it, and I took my bicycle. I didn't pump up my tires. I probably should have in hindsight, but took advantage of it and had a nice ride. Now, I probably, in hindsight, should have done a little more work over the winter because I couldn't walk for the next hour. But what I want you to think about this early afternoon is that bicycle wheel. So as I talked this morning, at the center of the wheel for Aspirus Arise and the health plan that I'm running in conjunction with WPS Health Solutions and Aspirus Inc., with what our health plan does, think of that bicycle wheel. Everybody owns one. You know what it looks like. But at the center of that wheel is a patient. And in the health insurance industry, oftentimes we call that person a member or a customer, but it's really truly a patient when they're entering into the health system across the board. And outside of that center hub of that wheel, I want you to think of 4 different spokes. The first spoke is to identify. So that's the first spoke that I'm going to just briefly touch on today. Identify. So patients at the center, we identify the members, and each individual, but in aggregate, our overall population that Aspirus Rise, that has our insurance. The second spoke that comes out is service. So it starts with an S, it's service, and it's connecting those individuals to the services that Aspirus Network currently has. The next spoke that I want you to think about and envision starts with an M, and that's monitor or measure. So how are we going to measure the success, particularly the outcome metrics? And I think we need to do a better job in this space ultimately as a health insurance organization connecting with the health system. But we really want to measure and monitor our overall outcome metrics. And the last spoke I want you to envision is to improve, because it really is a continuous cycle of improvement of a wheel of constant improvement. I think that really crystallizes where we're at as a country, as a state. I used to run the state's Medicaid program, and it's a constant improvement cycle of identifying populations, serving them to the best of our ability, measuring our outcomes, and then ultimately improving that work that we do. So how do we as Aspirus Rise identify our populations? We're a new health plan. Effective January 1, we had almost 15,000 members. 2/3 of that membership was on the individual exchange. All the issues you're talking about today, we can directly impact, and we take it very seriously. So how do we work with the Aspirus Network and Aspirus Inc., and how do we work to connect those systems? So first of all is through a health analytics management team that we organized and orchestrated to really dive into our overall populations. Because if you can't identify, I learned this in my Medicaid days, if you can't identify and segment a population and define it by healthcare codes specifically, now the beauty of a provider-sponsored plan, we also have clinical data and clinical information, so the richness of data that we have. But if you can't identify them, you can't help them. So that's step 1 for us. is going through and understanding who has a primary and secondary behavioral health code, whether it's substance abuse or other mental health issues, identifying those memberships. Then it's connecting those individuals to the services that Aspirus has. In the Aspirus system, as I've come to know and grow with the Aspirus system, I'm extraordinarily inspired. And I know the other health systems, Sheila will talk in a minute, they do terrific work. I worked with, when I was Medicaid director, I worked with the Marshfield Clinic Health System, I worked with Ministry Ascension, I worked with all the systems. We're all struggling with the same common things. So I think you'll hear common themes throughout. In the Aspirus system, I feel like they're extraordinarily innovative. And in large part, I liken that, there's several leaders within that industry, but I do want to call out one person because he's retiring in June, Dave Schneider, who is the president and CEO of Aspirus Langlite Hospital. I don't know if Dave's here today or not. I probably should have checked before I embarrassed them on Wisconsin Eye. Dave was really an impetus. I know Corey Norbaum, who we greatly appreciate helping spark and spearhead this organization, worked with Dave specifically, and many others, on community needs assessment in Langlade County. And the work that they're doing has been truly inspiring. And out of a lot of that work has been work that Dr. Sylvia Dennison, a psychiatrist up in Langlade County in the Antigo area, has done on creating hubs. And this is a best practices model, in my opinion, across the entire country. As I've seen different Medicaid programs and the innovative approaches that people are taking, we're trying to identify specific hubs with the psychiatrist, with clinical staff, and others to come in and meet the members' needs where they're at and what they need to improve on. So we're taking those best practices and trying to disseminate those throughout the entire organization at Aspirus. Aspirus Medford Hospital is starting to do the same. Weston will see some, I think, investments in that area, and Wausau in particular as well. So trying to, throughout a system, becoming one system, trying to improve and connect our members of Aspirus Arise to those specific services within the Aspirus system. Another trend that they're working on specifically is having nurse practitioners also be licensed mental health professionals. It's an extra additive bonus to be able to go and have one person that they trust. To me, it's all about a trusting relationship. And if we can connect that person with somebody they trust, we're making progress. And it comes down to every single individual and identifying them and connecting them with that person of trust throughout our process. Next, I'll talk about, and I know we'll probably talk about question and answer, so I won't go too much into detail, but I do believe that telehealth, telepsychiatry is an important venture that we have to do a better job on ultimately. Aspirus does have telehealth in their facilities right now. It offers, and insurance companies, we pay for that service. A member has to go into a clinic setting and can connect remotely with somebody throughout wherever they're at in the US. But I think that there's a vast need of access for our members for different types of services, and I think telepsychiatry or telehealth, depending on how people are defining it, I think is an area of opportunity that we'll continue to explore. The next part of that I just want to briefly touch on is monitoring or measurement. And I truly believe we've got to do a better job. And again, I don't mind if it's a competitor of our insurance company or if it's an association that we work with. I come from that Medicaid director mindset where we say we have to lift all boats up. That's why all of you are here today. What are the common problems that we can all work on, that we can measure in a common way and raise all boats up? I serve on the Life Committee for the United Way here in Marathon County, and that's specifically the question that we're asking ourselves. But I think we would be remiss if we didn't look to the SAMHSA and the National Quality Forum's behavioral health framework that they're working on right now. If you want to look to the cutting edge across the country, that's where it's at. They lay out their goals, they say, here are the measures that we're thinking about doing, and here's the challenges or opportunities that we might have. So we're taking that work of the National Quality Forum very serious. Aspirus Network has about 54 different measures that they have in their clinical value program. So we're working to match up those types of metrics that they're working on with what's going on in the National Quality Forum, tying that back with what's happening with United Way of Marathon County, and asking ourselves the question, what can we do internally to do more? Because I think oftentimes we have great conferences like this, everybody is well-meaning, we're all ready to go and geared up, but then everybody goes off in a slightly decentralized way, and we don't pack that large punch. So the ability for all of us as leaders to come together and stay focused on a common problem and not get distracted, I think will be the number one key that we have to taking improvement. So that's my challenge for everybody here today, is and my challenge for myself as the leader of Aspirus to rise, and with our partners within Aspirus to say, what can we do? Are we doing enough? If not, what do we have to do? And connecting with our partners to improve the quality of life for that patient who's really at the center of that bicycle wheel. And ultimately, we want to get people back up, riding their bikes, enjoying the sunshine, because that is what this is about. It is about people. It's about members, our members, and having them enjoy their quality of life. So thank you very much. I can't. Yeah, I have to about 11:45. Can I sit here?
Yeah. Thank you. Next, I'd like to introduce Sheila Weix, who is the director of the Substance Abuse Services for Family Health Center of Marshfield, Wisconsin. She has a 40-year history in the area of substance addiction, and I would like to welcome Sheila.
Hello, late morning. So I'm going to give a disclaimer at the beginning. I am with Family Health Center of Marshfield Clinic Health System, and we indeed have opened an addiction clinic in Minocqua in response to the opioid epidemic and other needs up in that area, and we're involved with the HOPE grant. But given what the nature was of this particular conference, I decided to speak more broadly. I'm just going to talk to the barriers that are encountered when a person wants to have addiction treatment in terms of insurance. So this is not aimed at any one insurance or any one system. We have multiple very good systems in the area, but this is just kind of what it actually ends up being. So I'm going to ask you to think about 3 disease states. One of them will be diabetes, one will be cardiac, and the other will be addiction. As you think about those, you know from Dr. Seppala's presentation and some of the other speakers we've had, that all of them have a genetic basis. There's genetic risk factors. All of them have an environmental piece. Has to do with what you do, some life choices, that kind of thing. There's toxic stress. And all of them do occur here in central Wisconsin. The difference is when you go to get care for it. So, as I mentioned, everything is a chronic disease. But if you look at diabetes, it is actively screened for in primary care. Care is available from a wide selection of qualified providers covered by insurance, regardless of what insurance it is. I am not aware of any health insurance in this state that doesn't cover diabetes care. 70 to 80% of the people with diabetes are able to receive treatment. And they tend to get treatment even if they're not particularly compliant with their diet, their exercise, or their medication. We just keep working with them, look for what the barriers are, and continue to help them manage. Then we talk about cardiac events. There are excellent cardiac services in this region across all of the providers. It's standardized emergency responses and interventions. There are probably people in this room who either have been the recipients of that care or know someone who has and has lived as a response to that excellent care. The outcomes are monitored and improvements are added, just as Brett had talked about. That's one of the reasons it's so good, is because that happens. And the services match the diagnosed need. We'll talk about that in a moment. So that's a disease of the heart and circulatory. Diabetes is a disease of endocrine and other systems. But addiction is a disease of the brain, as Dr. Seppala pointed out. It's a chronic disease with acute care needs, but only 1 in 10 receive treatment of any kind. And keep in mind, the 1 in 10 who receive treatment, those are the ones that are actively seeking treatment. There's a large number that don't even seek treatment. The acute need may result in some or no medication and a phone number to call. That may be all you get when you go looking for help. The parallel would be if you presented at an ER with chest pain, they gave you a bottle of nitro, some baby aspirin, and the number to call for cardiac rehab. And oh, by the way, they're booking out 5 weeks. We would not accept that. These are all health situations that need to be addressed. So you might ask, why does that happen? And I really think it all goes back to stigma. Because whether you're talking addiction or any other brain disease, we're back into behavioral health, there's always stigma attached. If you also keep in mind that many of the people with addiction also have other co-occurring mental health diagnoses, it's a very, very difficult position for a patient or a family to be in. So just some of the barriers. Insurance in place does not guarantee access to the level of care that's needed. ASAM, the American Society of Addiction Medicine, has developed a very workable set of criteria that tells you, based on this criteria, looking at the person's whole situation, going back to what AJ had mentioned earlier about those dimensions. This is actually 6 dimensions. Based on that, they can say, this is the level of care that this person needs at this point in presentation. I can tell you that most places have only outpatient available. They may have medical stabilization, but there's not much in between. There's occasional day treatment, but that may be limited by where you live. There's a lack of providers. Not enough are out there. There's not enough to meet the need. Part of that is reimbursement. If you're a healthcare provider and you want to have a really good business plan, you're going to provide joint replacements, you're going to provide cardiac care. Those things flat out pay much better. There is very little payment for addiction services. There's caps on numbers for that can have MAT. It's 30 the first year, 100 the second year. You can get to 275, but that is a lot of patients. For those of you who are in my age bracket and maybe looking at the future, Medicare does not cover substance use disorder counseling by anyone other than an MD or PhD, and that's not usually who's doing it. Mental health and addiction services or treatment needs are often occur in the same patient, but the treatment doesn't always occur together. So it may be a matter of having to decide where you're going to go or which one you have time to go to, which one can you afford to go to. There may be a prior authorization for the meds to treat addiction versus the fact that you used to be able to get pain meds without any prior auth. The length of treatment may not meet the need. There's times, if you're going to be paid for by a particular insurance, that you can stand inpatient as long as there's very acute needs of detox, but at the point where you are no longer detoxing, if you're not suicidal, you need to be discharged, whether your needs match that or not. In many cases, there's no structure or safe environment to allow stabilization. Many of the other speakers spoke to that. That's a really important piece with this. It's not just the medication. There are variations in what medications are covered. As they were looking at the insurance companies that would be in the marketplace for 2017, there was not a single one that covered all 3 medications, methadone, Suboxone, and naltrexone for opioids. And then there's the complexity, the systems for someone attempting to navigate. If you go back to what Dr. Sepala presented about how the brain is rewired and how it functions, try and work through the systems to get the help you needed. Likewise, as the Voices of Recovery folks presented, there are many, many barriers. It is hard to get through it. On a positive, well, I've got one more negative, sorry. In 2015, $9.6 billion was spent in opioid pain sales, but only $445.7 million for treatment. So 21 times more money was spent on buying opioid pain meds than was spent on treatment. That's under the negatives. So anyway, so what is changing? Some of the insurance companies are doing away with pre-auth for addiction meds and adding limitations for pain meds. That's great. There's tracking and feedback for prescribers so they can see how they compare to others. Case management services are being offered by some insurers. That's extremely positive. And there are patient financial navigators that are popping up in addiction clinics. We have one in ours, and I've had patients in tears, not about the other care we're getting, but about the fact that they got help to navigate the financial. So there is great concern around the current legislative efforts as they look at, on the federal level, what's going to happen with health care. I can tell you that for this population, needing to be a part of the essential services and to not have pre-existing conditions will be important, whoever is making whatever decision. So just a couple suggestions for you personally. If you have insurance, check your benefit for addiction treatment. Who are the covered providers? How close are they to your home? Do you have all the levels of care in your network? And how would someone actually access the service? This is one of those things that you don't want to wait until you really need it. It's going to be hard to do it then. Thank you.
So just a couple minutes for questions. I'd like to just start with asking about the challenges that many people face, as is mentioned several times today, is navigating the system. Many people wake up and decide today is the day and they'd like to make a change in their life in a positive way, but run into significant barriers in accessing the services that are available. What are both of the health systems kind of thinking about in terms of community navigation and other kinds of things that start more at a ground level hospital to assist patients to enter the system at the appropriate place and get the treatment that they need.
I can start. Hopefully my microphone's still on. Well, I think the first thing, there's a phone number that's very present that people with behavioral health needs are able to just call in. So a one-stop shop for that type of service. I think that's step number one. I also think that we have to be much more proactive, which is what I described a little bit earlier. The health resources team, which I think there's a few members from Aspirus that might be here. Please raise your hand in the back there. So the individuals that are here right in the center towards the back, they're the individuals that are the front lines. They are the ones that are constantly reaching out to the people that we've identified with needs ultimately, or if people start calling into the system, they'll get routed ultimately to these individuals to help out. And that's our proactive approach. We're trying to eliminate the needs for somebody to have to navigate this complex system. I mean, if you have comorbid conditions, if you have hypertension, diabetes, or congestive heart failure, and you also have a substance abuse concern going on in your life, it is extraordinarily difficult. You might be seeing 4 or 5 different specialists ultimately. So wrapping care management services around there, having them easy to place to go to. I do think, and I'll close with, I think we've got to do a better job of communicating with our members. I don't think, if you surveyed 10 members that were out there, probably 1 or 2 of them would know where to go. And I think that I take that on as my responsibility in working with the Aspirus network specifically to make services that are available I used to serve on the board of the Wisconsin Literacy, so health literacy is clearly important as well, and we have to be able to communicate in a language that people understand.
Well, a couple of things. If you have commercial insurance, look at the number on the back of your card or go to the website. That's probably the easiest way to access because we cross multiple different insurance companies, so there's not a one-stop answer for that. There is the Substance Abuse and Mental Health Services Administration, SAMHSA, treatment locator. That's an option. Wisconsin Department of Health Services also has resources listed depending on what you're looking for. But none of this is really easy, and I can tell you if anyone was having chest pain, they would know exactly what to do today. And going back to what AJ had talked about earlier, we need a no wrong door. It shouldn't be as complicated as it is, and we also do not have all the levels of service that we need. No one does, and that's a challenge. There needs to be the right treatment if we're going to look at outcomes, because I gave that example with cardiac. There would not be good outcomes with that cardiac population if it was nitro and baby aspirin as the total interaction. And yet we do that with addiction all of the time, and it's been okay. And you'll have to wait 6 months to go someplace, or there's no funding. There's an entire paradigm shift that has to happen if we're going to have something different as an outcome.
Great, thank you. Another question, since I'm the Dean of the Medical College and very concerned about producing the next generation of healthcare providers, I also see Dr. Ed Kralls here, who's the residency director for our new psychiatry program, which will match its first 3 residents this summer, and they'll start in July. What are suggestions for the community in how to promote the recruitment and retention of providers? A lot of these folks will need to be on the front lines, family medicine doctors and emergency physicians and counselors to our community. And what can we do as a community to increase the likelihood that we can attract and retain those frontline health professionals in addiction?
Okay. Part of it is going for homegrown. People who've grown up here are the people who will want to live here much more likely than somebody who comes from a large urban area. Also remember the people who, when they graduate from high school, can't wait to leave, and then they get to a certain point in their lives and they really, really want to come back. Look to actively recruit those people who understand rural life and want to be in this area. One of the things with the residency program, again, where you learn, it tends to be an area that you're open to being in. And always remember that that person who starts at an entry-level position with the appropriate support, mentoring, and access to financial aid may be that person who's ultimately a provider before they get done.
I think in addition to the stuff that Sheila said, I honestly think that in this area, and particularly in Marathon County, because I've participated in some of the conversations, I think a lot of it's happening. I think you just have to look at the work that Jeff Sargent is leading with the United Way of Marathon County, the Life Committee work that's going on. I mean, there's significant resources within Marathon County specifically, working in partnership with the business community and the nonprofit organizations to promote to promote north central Wisconsin. I mean, walk outside right now. Who wouldn't want to live here? I mean, this is the best place on the planet to be working and living right now. So winters can be a little tough. Yeah, we got to get over that. But you know, just enjoy skiing or the outdoor sports. I mean, there's a lot that is actively going on that I think we have to just help promote. And just, you know, my challenge to each one of you is understand what is happening. Because oftentimes, as I've learned in this role, there's a lot of that stuff that's already going on. Don't reinvent the wheel. Just put the puzzle pieces together and take a microphone and tell that story and trumpet it. And I think that's the best thing that we can do right now.
Okay, great. We're running a little behind, but I want to give a chance for one or two questions from the audience. If anyone has a question, if you can stand up and speak very loudly, and I can repeat the question. Anybody?
Sheila will take all the hard ones.
This gentleman here.
I'll take one question, or offer up one question, and that has to be, with all the panelists that have appeared this morning, I would ask you to speak on behalf of this. Parents tell kids, don't smoke. Smoking's bad for your health while they're puffing on their bicycle or their L&M. And the kid is supposed to look at mom and dad and say, yeah, you're telling me not to smoke, but you do. We've got a lot of things happening in our society. I'm wondering how you had to adjust your message, because we get states like Colorado and other states where all of a sudden they're telling people something that used to be forbidden is now acceptable, and they encourage it and put it in as a budget line for marijuana and the growth of marijuana and the impact that it has on the economy of their state. It's got to go very counter to what all the panelists and all the people who have spoken already this morning have had to try and recreate and say, no, this is. So my question becomes one of, how is what's happening in society and the political movement and the approval and the acceptance of a lot of things gone counter to what the very things are that you're trying to do to de-stimulate people, drug trade and all those other things?
Oh, go ahead.
I'm just going to repeat the question in case people couldn't hear. It was related to the messaging that's happening around the country, related to what's happening in Colorado and other places with legalization of marijuana, and the societal and parental role modeling and messaging, and how are we going to counter that or deal with that?
I think at the root of your question, which I think is a terrific one, is who's establishing the cultural norms in our society today, both across our country and in our state, in our local communities, and specifically in our home. I'm a personal believer that it starts in the home. And when there are bad role models at home, you're going to start to see that next layer. That's when school districts have to get involved. That's when the county has to get involved. That's when the city starts engaging. Other nonprofit associations do. I have 3 young kids at home. I have a 12-year-old son who I'm raising in this environment, a 10-year-old daughter, Audrey, who every day we start thinking about. And my wife and I said, well, where's the owner's manual for this? How do we engage in these types of conversations about legalizing marijuana with our daughter, who's hearing something on the news at night? And these are challenging questions. I think personal responsibility, it starts at home. There's a lot of activity going on currently across the state, but in particular, I'm aware of Marathon County is working with the school districts to put counselors for mental health services into the schools. I don't think it's finally completed yet, but they're working very hard on it. If it's not happening at home, which it won't oftentimes, we've got to take other proactive measures. And I'm proud of the work that's being done there, and Aspirus to Rise certainly looks to help partner with them.
Okay, and I have a couple of comments. So first of all, for those of you that were around for the 60s and 70s, we've seen sex, drugs, rock and roll before, and we've gotten through it. As somebody mentioned earlier today, this isn't the first run at methamphetamine or heroin or some of these other things. And so sometimes the advantage of tenure is you have the long view. So there are several things that make a difference. One, as Brett mentioned, support and things at home. But other things that we also know is that there are a tremendous amount of work with prevention going on through the coalitions. So actually alcohol, which is legal and has been around forever and is still our #1 problem, actually alcohol use has decreased in our younger people. They're not doing it as much. So those prevention things work. Likewise, if you think back to smoking, it wasn't that many years ago, smoking occurred everywhere. It doesn't now. So we're able to move things. So being aware, supporting your families, supporting the positive things in the communities are all things that help, and then having access to services for those who need it. Another major piece, and Brett mentioned the mental health, remember that the adverse childhood events are huge.
So the more we can do to prevent trauma to our kids and to support them in positive ways, the less likely they are to reach for addictive substances to try and cope. So it's all connected. It's healthy communities, it's positive supports, and it's recognizing and treating when needed without stigma.
Thank you very much. I appreciate, and please thank Sheila and Brett for their time.
Thank you.
Thank you.